So let's sort of shift focus a little bit. I was real impressed with what Kate was saying about the mobilization of patients with the LVADs and with the ECMO. I think that's incredible because that is going to help us in the future to address one of the major issues that has come up, not just sort of appeared, it always was there, but we're just now, in the last, I would say, 5 to 6 years, really becoming more and more aware of post-ICU syndrome, and we'll talk about that. I have no disclosure. So what I want you to do is I want you to close your eyes. Close your eyes. Okay. I want you to imagine yourself in an ICU. Can you hear that? Okay, you're in an ICU, you have an arterial line, you have a ventilator, you have a Foley catheter, your family's not there. What's going on in your mind? Okay, open your eyes. Whoops, let me stop that. Was the noise too loud? Was there anything particular that bothered you about that moment that you realized that you were laying in a bed and your hands were down, you had a tube in your mouth, you couldn't talk, you couldn't really move like you want to, you might even had a restraint on, and you didn't have any family around, you had all these people looking over you. What are your thoughts? You don't have to answer that. In the past, we focused in the critical care areas really on survivorship. We wanted to be sure that our patients were getting well and getting out of the unit as quickly as possible. We wanted to make a difference in the outcome of the patient from the perspective of the ICU. What we've discovered over the course of time is that we're now recognizing that these moments that these patients spend in the intensive care unit really impact what's going to happen to them the rest of their lives. For some patients, it's not a real big thing. For some patients, for some reason, they don't really have they're not really tremendously impacted by this critical event that happens to them. But for many, we recognize that there is a significant change. Survivors often suffer, as we see, from multiple morbidities, not just chronic renal failure or some other problem related to their GI system or that, but cognitive, psychosocial, as well as mental illnesses that can occur as a consequence of being in the ICU. And this is what we call post-ICU syndrome. In 2011, in Washington, I actually identified that mortality was markedly decreasing, and we had higher and higher increases in survivorship in the ICU post-care. During this time of survivorship, we really did not have an idea or perspective of what was going to happen to that patient and what was going to be the outcome of that family and how they were going to be affected by what occurred in the ICU. As recently as this year, 2018, we're now retrospectively looking back at this population of patients, and we're recognizing that in all of these patients, up to 72 months after discharge from the ICU, patients are still experiencing significant cognitive impairment. And for about 50% of the patients that we see that leave the ICU that have PICS, they do not return to work or to their past jobs, and their normal becomes a new normal. And they're looking at something totally different as a future in managing their lives. We have recognized over the course of the last 10 years that there are significant risk factors to what we call PICS. One of the biggest risk factors we've identified is that of delirium. And we've made huge headway in early recognition of delirium and identifying what we can help do strategies to prevent delirium. But it's important that we recognize it, and it's important not just in the ICU, but in the general care areas as well, particularly for those long-term patients that remain in the hospital. We recognize that pain and anxiety, restlessness, we recognize that physiologic changes like hypoglycemia, hypokalemia, pre-existing diseases, prolonged mechanical ventilation particularly, as well as heavy sedation. How many of you now wake your patients up every day and assess their level of activity and their level of function, and then let them go back to a lower level of sedation with the idea of getting them off sedation as quickly as possible, because we recognize that. And not only that, but we recognize disease entities that our patients experience in the ICU that are great contributors to dysfunction after they leave the unit. Rummel in 2014 did a research study looking at about 125 patients that he finally looked at in his study, and of that, 44% of those patients had absolutely no symptoms of PICS whatsoever after they left the ICU and were discharged from the hospital. But another percentage of those patients were divided among 3 categories of physical, cognitive, and mental health challenges or issues post-ICU. Needham, in a publication he did in 2012, went a little step further than just identifying the domains that are affected in PICS, but also looking at the family components of PICS. How many of you see families, how many of your families are actually in the ICU in the room with the patient all the time? Hands? A lot. That's the wave of today. It's different from what it was when I was a young nurse. And where only one person could come in and visit at a time for 2 hours a day or something like that. We don't do that anymore. But as a consequence of that, we have this family component of PICS that they experience as well, because they're watching this happen. They're seeing all the bad things, and they're not able to really do anything except watch. And that contributes to what happens when the survivor actually experiences PICS. And the things that we've identified, Dr. Needham identified specifically, was the specific things related to these domains of cognitive, mental health, and physical impairment. So let's look at the 3 components briefly. Cognitive impairment is almost universal in the ICU, and there's a direct correlation with delirium. And the more extensive the delirium, the longer the delirium lasts, the more likelihood there is going to be cognitive impairment after the ICU. Most survivors in the ICU have measurable cognitive impairment. While no really randomized controlled trials have really shown improvement, they do accept those that are related to stroke, post-stroke patients. And so we're utilizing a lot of that content that was evolved as a consequence of stroke patients and looking at what cognitive changes happened and how we can identify those cognitive changes and how we can improve outcome and what strategies we can actually implement in the ICU while they're there to help improve or decrease the risk of cognitive impairment. There you go. So Mona Hopkins one more slide. I went too far. Back up. Just want to go back one. There, okay. It's skipping 2 slides.
Yeah.
I don't know why.
Don't know why.
Okay, hold it there. That's good. Okay, cognitive outcomes also were identified in a population of 413 patients, but I found this very interesting. No impairment was found in over 50% of the patients. And of those others, the severe impairments are only in about 21% of patients. So how do we know who those 21% are, and how do we recognize the risk of those patients? We've identified what risk factors could be, but how do we begin to recognize that before they actually leave the hospital? And how do we make an impact on those and change that? So Mona Hopkins and Jim Jackson did a chapter in a book called The Legacy of Critical Care. And in that chapter, they began to do some sort of trajectory about what would change and how would it change in the normal aging process, as well as in those patients that, as they grow older, have experiences in critical care. And what they saw, and I thought was quite interesting here, in healthy aging, and I didn't like this idea, at age 55, we began to show changes in our cognitive status. Now, I'm 64, so I don't want to think about the fact that I should already have significant cognitive impairment because I'm beyond 55. But the reality is, between 55 and 65, we do see changes in cognitive ability. And that's the normal process of aging. But let's say you throw a month stint in the ICU for heart failure, or a month stint in the ICU for a perf valve, or that kind of experience into this aging process. So I'm growing older, I'm older now, I'm in the 75-year range, this experience happens to me, I already have some cognitive impairment by nature, and now I'm beginning to develop delirium, I come out of the ICU, I get a little bit better, and I may recover to a new normal, or I may never, ever really regain my ability to go back to work, my ability to drive a car, those simple things, and I would develop a totally new baseline. And some go to a very severe and have no recovery at all. So this trajectory is sort of frightening to me when you think about the populations of patients we're caring for that are greater than 55 years of age. unless you work in a child pediatric rural. So I think this is important for us to take into consideration as we look at our own practice and how we can better identify these situations. I don't know when I'm not pushing right. There we go. So another component that we have to look at is, we looked at the cognitive realm, we have to look at the mental health realm. And this one to me is the one that really frightens me. You have patients, have you ever had a patient, I do, come back and say, I was assaulted when I was in your unit. Have you ever had that happen? We've recently had that happen. And it was, what was really happening was the patient received a Foley catheter and a bowel management system. And that happened to them in their ICU, delirious state. And of course, how do you explain that to the patient? You can't, it's hard to explain that to the patient, help them understand. What about the patient who says, I had nightly visitors in the ICU and I was in a gym and they exercised me until I was totally exhausted. An ICU patient states, I just don't think I can go back and do this anymore. Or they state they had visions of big spiders surrounding them all night long, night terrors. These things happen to our post-ICU patients. They happen in the unit when it's happening to them. And sometimes the behavior that we experience with them fighting against us is not because you're hurting them, it's because they're frightened, because their brain is operating, but their vision's not working, their hearing's not working. And so they're not really seeing you as you really are and what you're trying to do to help them. In 2013, a study was done by Karen Barrow, and she basically stated patients who have prolonged stays in the ICU, getting intubated, sedated, may experience severe hallucinations, putting them at risk of PTSD in years to come. And so what we've identified is that there is a psychological change, anxiety, depression, those kind of things that happen to these patients when they leave the ICU, and many times it's not even picked up until they're home and they just can't seem to get their self up in the morning. They can't seem to do the things that they normally do. Things that never made them anxious before are making them anxious now. This is really kind of a very hidden process that you might not recognize early on in your patient population. But it's severe and it can be very dangerous to your patient's outcome. I want to take you to a quick visit to AJ. AJ is a 34-year-old male who was admitted to our ICU. I was going to put his picture up there, but I realized I didn't have permission, so I didn't want to put his picture. I didn't put his picture up there. But he was a pretty dramatic young man. He was married, he had 2 little girls. He was admitted to our ICU with streptococcal bacteremia. He had a prolonged phase of septic shock, vasopressors, the whole 9 yards. We're talking weeks. He had severe ICU weakness. Was unable, in myopathy, unable to sit up in a chair, even sit up in bed for a prolonged period of time. He was on the vent, he had a trach, 37 days to wean off the ventilator, and resulted in severe fatigue. His sleep was often disturbed, and he told me this at our 5K that we had this past year for our ICUs. He came, and he told me that he had trouble when he first got home falling asleep at night. He just couldn't do it because he kept waking up frightened. And he didn't know why he was frightened. Fortunately, his wife was with him day and night around the clock, and she saw the whole thing, and she was able to comfort him and help him understand what happened to him. He lost, because of a lot of things, he lost his right hand, pretty much. He lost fingers off his left hand, both legs below the knee. And he had ARDS, renal failure, and was dependent on dialysis for a period of time, and respiratory failure. Yet he survived. He came to our 5K after being discharged from the hospital for a month, and he walked with his family on his new legs. And he told me that this coming year, he's coming back this year on his sickle legs, and he's going to run the 5K instead of walk it. This man was totally devastated. He has major physical disabilities now as a consequence. He's cognitively intact, except for the night terrors that he had initially when he got home. He's not had any major issues. But this is an extreme case of the physical changes that patients have. Get a trach, that can be a physical problem that you don't want other people to see that, and you wear it and cover it up. Or all the IV punctures and all the lines that they have when they're in the ICU. So the physical is more visual to us, but it is a significant impairment that our patients experience, along with the psychosocial and the cognitive. Muscle weakness, atrophy of the muscles, disuse because of bed rest, ICU-acquired weakness. 50% of our patients post-sepsis with multi-organ failure have ICU-acquired weakness. That's significant. 90% of our patients have abnormalities at 5 years. And this was a study done in 2009. And additionally, our ARD survivors now, even ECMO and non-ECMO patients, actually have a 66% chance of being normal within a year, but half of these never return to work of any kind. 68% after 2 years, they still have long-term consequences of their illness. And so this is pretty significant and powerful. So the first question I would ask you is, which of the following has been identified as a major component of the post-ICU syndrome? Because this is what it's important for you to take back to your place where you work. I go to the next slide. You go ahead and do it. Save time. Mm-hmm. I'm not doing something right. Okay. Oh, sleep deprivation, 40%, cognitive, 44%. So, based on what we've just said, the three major components for you to take back with you are cognitive, yes, absolutely. Sleep deprivation is a consequence, but it's not it's the psychosocial, the psychological, impairment that you might see, and then you have the physical impairments. So cognitive is the specific one that you might see as a defined characteristic or criteria. I don't know what I'm doing wrong here.
I think that remote is a little...
Yeah, it's not working well. Okay, go to the next one, please. So the other piece we need to look at is we've defined what happens to the patient, but you also have to define what happens to them when they leave the unit and what do we contribute to that as providers. So survivors often find themselves weak and afraid, as we've talked about. After leaving the ICU, they also often feel abandoned. When they go to the floor, a lot of our families will come back to the ICU to visit and bring the patient back to the ICU when they can because they like that environment. They felt safe. They had one nurse. They had a surrounding number of people around them all the time. They felt much more confident and secure. So that sense of abandonment is really strong. Changes in their self-image can occur, and they may still die of their illness. This patient here is Mr. T, and he was in the ICU for a prolonged period of time, and he just had his walk on the ventilator, and now he's sitting back down at the bedside, and his comment was, I'm amazed. He couldn't believe this had happened to him, and he was able to actually, he was alive and survived this. But what do we do in contributing the changes that we do to that patient's post-ICU? Our care after the intensive care stay is very fragmented. Sometimes we transition our patient to another service when they leave the ICU. That service doesn't know their whole history. They may not get started back on their home medications. They may be put on antipsychotics in the ICU, but they don't need that to continue once they leave the floor. They may have antihypertensive medications that they were on pre-ICU, and now they're out of the ICU, and that's not restarted. Things happen to them that we do not look carefully at because we don't look carefully at. And we may need to make sure as ICU care providers that we're addressing these issues when they leave the unit as much as possible so that our handoff is safe to the people that are caring for them, and these things that need to be restarted, or if ongoing care is needed, it's there. Mortality is still a huge issue. 26 to 63% of these patients they actually have mortality in the first year after recovery. Risk factors we've already identified. I'm moving quickly. I'm trying to. But we have to take into serious consideration the fact that our patients experience all of these things, and the family along with them experiences these things. And so as we begin to treat and address these issues post-ICU, how can we do that and help both the family and the patient? And how can we help them have a better outcome? How can we keep them engaged in care? How can we create the right environment for them while they're in the ICU? And it's, I think, very, very important that their families are able to be with them in the ICU. I think that decreases a lot of their fear and anxiety and helps to improve their outcomes, mainly, in my opinion, because they see what's happening to them. And the family knows this happened to you, that what you think happened didn't. This is what really happened. And that makes a difference in their outcome. You need a new thing. So, strategies. What are the strategies that we can do to minimize PICS? These are the basic ABCDE bundle that we see now that we've been working on for a long period of time. Delirium being the number one thing we really need to decrease. Length of stay on the ventilator, another major thing we try to decrease. But what can we do? Early mobility, very, very important. Get the patient out of bed, sit them up in the bed, turn them side to side, wake them up, make them aware that they're not totally bedridden and dependent, if you can possibly do that as soon as possible. Follow up with referrals. And this is an area that's being evolved right now through the Thrive Initiative and the Society of Critical Care Medicine. We're looking at post-ICU clinics. We're looking at peer support groups. A publication will be coming out, as one was just published in post-ICU clinics and how to design those and develop those. We published one last year on peer support groups and how you can evolve those. We have support groups all around the world, and we have post-ICU clinics now all around the world as a consequence of this initiative, trying to reach out to our critical care world and let them know what this impact this disease has on our patients. Good handoff communication is really, really important to make sure that things need to be covered appropriately with the patients, the patients when they transition from the floor to the ICU. Hand patients' families information to prepare them what to expect in the ICU. Let them know up front this could happen, and let them know up front these are things we try to do to prevent it and try to do to improve it and help it. ICU diaries are huge, and studies have been done to validate the ICU diary is a great benefit to our patients and letting them know what happened to them in the course of their care. All disciplines contribute to the ICU diary. It's not just the patient or the patient's family. There has been absolutely no data yet to show that there is the true benefit of the ICU diary. It's sort of a 50-50 kind of situation as far as the data shows, but the families and the patients say that this is a really good tool. Complications or not complications, challenges that you have with the ICU diary or litigation, issues people are afraid of. We don't want to do a diary because they may sue us for something we did. Those are all things that need to be worked through. And it's the way you do the diary, and there's a lot of good literature out there. We don't have time to cover it today that actually can give you examples of how to design and develop those ICU diaries. Real quickly, I want to just mention the RISEN trial. This is a recovery, not trial, but a program that's looking at the ABCDE bundle, but also looking at mobility, exercise, and nutrition, and how nutrition in the ICU can contribute to complications and problems. It's called the RISEN trial, and it was published in 2015, and it is ongoing in different locations around the country, and I would encourage you to look that up because I think it has true value and that it's looking not just at the physical things, but the actual nutrition that we give our patients in the ICU. In our unit, we've started a mobility trial using the AMPAC tool as a functional assessment of the patient, helping to mobilize them early. This is a tree that we've developed, and our Dr. David Trong has worked with us in developing this process for our unit, and we're actually doing this now in all of our ICUs in our hospital, and it's a really good process. Red, green, and yellow. Red is hemodynamically unstable, can't do much. Green, they're getting out of bed, they're mobilizing. Yellow, they're getting out of bed, mobilizing, and green, they're standing, able to get out of bed pretty much independently. But it's a good tool to begin the process of early mobility. So the question to wrap up with, I went past it. Strategies to help prevent PICS may include, which are the following: early mobility, ICU diaries, peer support groups, all the above, A and B only. A strategy to prevent. Peer support groups don't happen until after they leave the hospital. Now, I will tell you, there are some ICUs now that are starting peer support groups in the hospital while they're in the ICU. Do any of you have that in play in your hospital? It's a great thing. You pull families together and have support group with the families while they're in the hospital to help develop and to help them understand what to expect when the patient leaves. There's some huge gaps and huge areas in research that we have to address. And some of these, I'm not going to read through all of these for you, but there's a lot of knowledge that we don't yet have. The longitudinal data is out as far as maybe 10 years, but nothing beyond that. But we know at 5 years, about 50% of our patients, 40 to 50%, still are not able to function at their normal baseline. So it's important for us to keep our minds open to opportunities for research to identify what strategies we can help to address and implement while they're still in the ICU. But even more importantly, don't forget cognitive, physical impairment, and psychological impairment all can be impacted by mobility, the ABCDE bundle that you just saw, ICU diaries. Those things can help improve outcome for our patients. And these are resources that are available to you online. My ICU, ICU Delirium, ICU Steps, and the Thrive Initiative all are on the websites, and they can help you with tools. They have screening tools. We actually are having a conference at ATS on May the 20th, where we're actually going to be looking at identifying screening tools that are out there that would be useful to you to help screen patients for PICS, and also to look at some models of care that we could recommend in the hospital as well as post-ICU. And I encourage you to use these websites. They're very helpful. We don't really have time for questions, so Greg, are we moving forward? Thank you very much.